and wake up the audience. What I'm going to do is I'm going to share with you the epidemiology of Dupuytren's contracture. And I've just got two main messages. One is the rate of surgery, and the second is the variation between units. And it touches on some of what Zsolt picked up there as well. So no conflicts over here. In England, what we do, it's very similar to what happens in the Netherlands and also similar to what happens in Germany, is that we collect data on every patient that comes into hospital and is admitted for treatment. And we code their diagnosis, and we code their diagnosis with an ICD-10 WHO coding system. We've got about 10,000 codes, and there are unique codes for Dupuytren's. And we also code each and every procedure done using the OPCS 4.5 codes, which are similar to your DRGs and other types of codes elsewhere. And each procedure that is done then gets a tariff, an amount of money, and we get a lot of other data collected, one of which is the length of stay. Now, the data that I want to share with you is on all the hospitals in England that are doing Dupuytren's contracture. And so over 2 years, 2010 and 2011, and over this 2 years, 34,000 patients had Dupuytren's contracture release. I want to concentrate on this one bit of data. Let me just get this. How do I use this? Okay, so this is called the funnel plot. Don't worry. Yeah, this is called the funnel plot. And on the x-axis, what you have is the population served by each of these different hospitals. And on the y-axis, you've got the rate per 100,000 population per year. And here what you have is the mean line, which is just over 50,000 per 100,000 population per year. So that is the rate in England. Now, these are control lines, and this is 2 standard deviations away from that mean, and this is 3 standard deviations away from the mean. So those are your control lines. And what you see over here is you've got all these units, and immediately what becomes apparent is that there is a large number of units that are outside the control limits. The large units do less surgery, so their rate is less. And the smaller units are doing much more surgery than you would expect. So the message is the overall rate is 56 per 100,000 per year, and there is a large variation between units. And if you look at the geography, it is not immediately apparent. The biggest unit is there. This unit provides care for half the population of this unit there, which is my unit. And yet it is doing 3 times the amount of surgery as in my unit. So there's quite a huge variation just 20 miles apart. Now, the second part of the talk is this, which is when you actually look at the total specific procedures done, the main ones are palmar fasciectomy and digital fasciectomy. And what I want to pick up is just a little bit of trend. The fasciotomy rate is increasing, but this is mainly by decreasing the palmar fasciotomy rate. There's exactly the same, in fact, an increase in digital fasciotomy, and the revision rate is about the same. So there's no change in the revision rate. This shows you the variation between all the hospitals, and the main message is there's a huge variation between hospitals, 8 times variation in rate using the technique which is used by the Department of Health in the UK. And I can talk to you later about the actual method that we used here. So the summary that you need to go away with is in England, we do 17,000 Dupuytren's cases per year, which costs us 60 million per year or 81 million euros per year. If we translate those figures across the whole of the European Union, then you're talking about 160,000 cases per year, costing about 750 million euros, quite a huge amount. There is a huge variation of 8.2 times, of which 7% are fasciotomy, and this is slowly rising. Revision rate is steady at 7%. It's not what we are seeing in the literature. And the dermofasciectomy is very, very small. And to reiterate what Zsolt said earlier, it tends to reflect preference rather than evidence. Thank you.